Okay, this is part 2 of septic shock, and remember that shock in general refers to circulatory collapse. And we're talking about low blood pressures. It is the systolic blood pressure is the parameter that we use to monitor our patients who are in shock. Now, SIRS stands for Systemic Inflammatory Response Syndrome. A patient is said to have SIRS if they meet 2 or more of the following criteria that you see listed here. A temperature of greater than 38 degrees Celsius, heart rate greater than 90 beats per minute, a respiratory rate greater than 20 breaths per minute, and a white blood cell count greater than 12,000. Of course, you can also find the opposite extreme of less than 4,000, but in general, we're talking about a white blood cell count that is elevated. Or perhaps they have a large percentage of immature forms of white blood cells, and we'll talk about that later in this presentation. But these immature forms that we're talking about are mostly in the form of bands. So there's segmented, they're neutrophils, but they're in the band form, and they're immature white blood cells. So if you have a 10% comes back on the differential, then that would also be qualified as meeting that criteria. So SIRS is the initial presentation that alerts us to the fact that the patient may indeed be progressing to sepsis. It is termed as sepsis once there is a documented infection. So once cultures come back and we've identified, or the microbiology lab has identified the organism that's causing this infection, then we say that the patient is septic. Severe sepsis is what we would call sepsis associated with organic dysfunction. In other words, the organ systems are now affected and not functional. They are also hypotensive and underperfused as well in severe sepsis. This progresses with time to septic shock. And septic shock refers to sepsis with refractory hypoperfusion and also refractory hypotension, despite the appropriate resuscitation efforts. And then finally we have MODS. MODS stands for multiple organ dysfunction syndrome, and that's when the patient who is septic now shows failure of 2 or more organ systems. So homeostasis cannot be sustained without support at this stage. This slide documents the mortality rate associated with each of these levels of sepsis. Okay, if a patient has SIRS, they have a 7% chance of succumbing to the condition. But you notice as this SIRS progresses into sepsis, severe sepsis, and septic shock, that the mortality rate increases. Sepsis, we've identified the organism, and so now it has a 16% chance of leading to mortality. Severe sepsis, it's 20%. And then if a patient progresses to septic shock, it's close to 50% mortality rate. So clearly we need to intervene early and do aggressive treatment to prevent it from progressing. To document the hematologic and metabolic conditions of patients with suspected sepsis or septic shock and help to detect the specific causes of infections, healthcare professionals need to assess a variety of lab work: a CBC with differential, and tests for serum electrolyte levels and renal and hepatic function are just some of the studies recommended. Coagulation studies, as calculated by the prothrombin time, and the PTT as well, can reflect potential for disseminated intravascular coagulation, which requires additional investigation. The use of blood cultures is the main method for diagnosing intravascular infections and bacteremia, while ABG analysis measures the amount of oxygen, carbon dioxide, and acidity. Now, I'm not sure it's on this slide, but we will talk about it. So also that you could add here would be the serum lactase levels. When lactate levels are elevated, it indicates the presence of hypoperfusion. With higher figures or numbers of lactate levels, it equates to a greater degree of shock and mortality. Now, urinalysis and culturing can be used to rule out the presence of UTIs. Gram staining may not only document bacterial infection, but also influence the type of initial antibiotic therapy that is chosen. Other diagnostic assessments include imaging studies such as X-rays, ultrasounds, CAT scans, and lumbar punctures. Okay, these are some of the tests that we just mentioned as far as the imaging studies. And again, it is the white blood cell count when elevated meets the criteria for SIRS. But also, don't forget, we need to look at that differential. Remember, the CBC differential is a count of 100 cells, and we're looking for peripheral white blood cells and counting the numbers of each different type. But when we see immature white blood cells in the peripheral blood, that can be an indication of infection. So this slide shows us some immature white blood cells, starting on the left with the most immature, and then progressing to the right where you see the segmented neutrophil. The segmented neutrophil is the mature peripheral white blood cell. That's the white blood cell that we should find when we do a differential. But if we count 100 cells and instead begin to see some of these early progenitor cells, such as myelocytes, metamyelocytes, and especially bands, then we are seeing immature cells in the peripheral blood. And what that signifies is that there is an infection in the body. The body is trying to respond to the infection by pushing out more white blood cells into the bloodstream. In its effort to boost the number of white blood cells, it ends up pushing out immature forms. They're not ready for the peripheral blood, and they certainly do not function as a mature white blood cell in fighting infection. But we can use it as a diagnostic feature, because if we see, for example, 10% bands in the peripheral bloodstream, that would indicate to us that there is a shift to the left. That's what we refer to it as, because we are seeing more of those early progenitor cells from the bone marrow that have been pushed out too early, and we call that a shift to the left. Okay, so make sure you understand that and maybe read up on it a little bit so that you can answer questions appropriately. And this does in more detail regarding that shift to the left. Yes, I don't think you can see my cursor. So we see on the bottom, we see a white blood cell and all the phases of maturation that occur as it becomes mature. On the right side of that arrow, we're going to see all the segmented neutrophils, and those are more mature forms. They belong in the peripheral bloodstream. And toward the left here, we see the more immature forms, the bands, as well as the meta and the myelocytes. So the more bands we see, the more severe their shift to the left, and that would indicate that there is a even worse bacterial infection. So when we see those immature white blood cells, and the more of them that we see, the more severe the infection. Okay? At this time, I want to remind you that in this septic shock module, you have a nice article called Septic Shock, and I would like you to read it. It really ties everything together that I've been talking about in this presentation. And let's see, we also have, well, it doesn't appear that there are questions. Let me see, maybe there are. Yes, there are. Okay, so there are questions associated with that article. There are 10 questions. So don't worry about the evaluation questions. That's not important at all. What's important is that you learn from the article. The articles that you've been given are very basic continuing education credits for nurses. So this is content that you are expected to really understand and know as a nurse. And I would like you to do those 10 questions, but for your own benefit and for the purpose of learning. Okay, so as you'll know, that the systemic blood pressure is the parameter we use to monitor our patients who have shock. Okay, to monitor their treatment, to monitor their response to treatment, we have to monitor their blood pressure. And that's one of the nice things about being in the intensive care unit. And these patients, certainly when they're this sick, need to be transferred to the ICU. Okay, when they're hemodynamically unstable, and we need to regulate their blood pressure. We have access to an arterial line. The A line or ART line can be in, as you see in this picture, it can be here, but it can also be in the brachial artery. And what it provides us with is a continuous blood pressure reading. This is very handy, needed when a patient is this ill with shock. So we have a continuous waveform on the monitor that tells us second by second, in real time, what that patient's blood pressure is. So remember, when we're talking about fluid resuscitation and vasopressors to try to get that blood pressure up, why do we need the blood pressure up? So that it can perfuse, the patient can perfuse their body, including their vital organs. Okay, so it's imperative that we get that blood pressure up. And we do that through fluid resuscitation, and then, if necessary, if that is not sufficient, then we're going to clamp down on the vasculature. Once we fill the tank, we'll clamp down with our vasopressors with the intention of getting that blood pressure up. So it's very handy to have this type of monitoring system for our patients. Now, the only thing that we have to worry about is safety with an arterial line. Because remember, this line is going in an artery. The arterial system is a high pressure system in the body. It's not like if a peripheral IV line came out. There may be some bleeding, but nothing like the bleeding that occurs when an ART line is dislodged or pulled out from the body. That's a really high pressure system, And so if that would happen, then the patient could actually esanguinate, meaning lose all of his blood and end up dying. So it's very important when a patient has an arterial line like this, first of all, that it's on top of the sheets, on top of the white sheets, and preferably on the side of the room where the ICU nurse can visually make contact with that site, so that we could see if there's any bleeding occurring, there would be, a large red spot on the sheets and that we could intervene. So that's a safety measure regarding any arterial line, something to think about in terms of safety. Now, another form of hemodynamic monitoring in the ICU is the central venous pressure, or CVP. Now, this catheter is inserted and advanced up through the superior vena cava all the way to the right atrium. The catheter tip is placed right at that juncture of the opening of the right atrium. And because it is a reflection of the pressures found there, it really is a reflection of fluid volume status, and in other words, the preload that is existing. So if we fluid resuscitate our patient, we want to make sure that we are not giving them too much fluid, too many fluids, okay? And one way we do that is by monitoring that CVP, because that pressure detected there by the right atrium is going to increase when the patient is in a fluid volume overload condition, or there's fluid volume excess, okay? And the CVP, that number will come down, just as if they are dehydrated, you would have a low CVP, and if they had too much fluid on board, then the CVP would be on the higher end. Remember, this is a continuum. The central venous pressure is a continuum. On one end it's low, and on the other end it's high. So this is something that needs to be monitored for our patients with septic shock, especially when we are in the process of resuscitating them with lots of fluids. Now, here is the definition for CVP. It's the pressure within the superior vena cava, or the right atrium. And it provides us information about the body's volume status. Okay. A normal CVP is 0 to 8 if you're talking about millimeters of mercury. They also have another unit that's used frequently when they are monitoring CVP, and that's sonometers of water. And that's why this range is different, because it's 3 to 8 sonometers of water. And always look at the units, but even if you were given this CVP value on a test question, it would be something very dramatic. So regardless of whether you knew it was millimeters of mercury or sonometers of water, really wouldn't matter. If I told you that the CVP was 15, clearly that's elevated, and we're on the end of hypervolemia, okay, or a fluid volume excess. We would not want to continue to give our patient more fluids because you're going to put the patient into a heart failure situation. Okay, so we don't want to put too much fluid on board and increase the preload too much. But if the CVP is on the low end, a 2, a 3, that's low on this continuum. And although it says it's less than a 0, but you could even put that if less than like 2 or 3, then you have a hypovolemic state. Okay, so on the lower end, 2 or 3 is lower. I guess the mid here between 0 and 8 would be around a 4, but certainly a 1, 2, 3, those are low numbers. And so that person is on the hypovolemic side, or dehydrated side. Okay, so let's talk about pharmacological treatment of patients in septic shock or sepsis. Okay, antibiotic therapy. Initiating antimicrobials as soon as the cultures are sampled improves their odds of survival. Remember, that goes back to your fundamentals. You always draw cultures before any other interventions, okay? Before you start antibiotics, you're going to get that culture first. Otherwise, you will never be able to identify the organism because it's likely that the antibiotic may have reduced the count so much that we can't even identify the organism. Broad spectrum antibiotics should be instituted within the first hour. A lot of times they'll start out with some third or fourth generation cephalosporins, like Rocephin, that's a nice broad spectrum cephalosporin, or cefepime. So either one of those would be good. If additional gram-negative coverage is needed, they can use gentamicin. If they suspect MRSA, Vanco would be added. It's after the cultures and the sensitivity reports come back, we can make adjustments to their antimicrobial therapy. Okay. And then other parts of treatment besides the antimicrobials include our vasoactive drugs, and we have already talked about those in a little bit of detail, especially in regards to our dopamine. And we talked about the different dosage strengths. And our high dose dopamine would be very good in terms of clamping down on the vasculature, causing vasoconstriction and improving blood pressures. And then also a patient may be on an inotropic agent. And remember, these are medications that strengthen the contractility of the heart. Okay. So there's all different types of medications that may be used in treating our shock patients. This is a nice slide and gives you some more detail about the type of vasoactive drugs that are used and indications for each of them as well. So for example, on this table, you see septic shock listed. So septic shock, you can use norepinephrine. That's a lovely vasoactive medication that you can use. Epinephrine as well, and dopamine. We've talked about all of those. And they also include one other, phenylephrine is also a drug that may be used. So there's some examples of various vasoactive drugs that can be used to raise the blood pressure in our patients who are in septic shock. Oh my goodness. I finally broke down and included a slide on dopamine. So here, because it is a commonly used medication in the ICUs, so you don't have to memorize this. I just want you to be aware that dopamine is dose dependent. You have low dose, moderate dose, and high dose. And at each of those doses, it has a different effect on the body. Okay. So low dose is really great for enhancing blood flow to the kidneys and even the liver in that area. So the moderate dose is great for causing inotropic effects, and the high dose is great for your vasoconstriction. Other treatments, certainly oxygen therapy. So remember, perfusion is the main problem in shock. Remember that lovely picture we showed earlier. So if we're having a real problem with perfusion at the microvasculature level, and good intervention is always supplying supplemental oxygen therapy. Of course, we'd want to establish and maintain a patent airway. During shock, catecholamines are released. Those are the stress hormones. as compensatory responses to shock increase oxygen demand, requiring optimum oxygen delivery and decreased oxygen consumption. Intubation and mechanical ventilation with up to 100% oxygen will be required as the pH decreases to decrease respiratory muscle workload and oxygen demand. Now, fluid resuscitation is of utmost importance. As we see on this slide, it says fluid replacement is the most effective treatment for septic shock. Okay, and when we say that, fluid replacement, we're talking about crystalloids. And here in the United States, it's mostly normal saline. If you go over to Europe, they use mostly lactated ringers. So we need to have plenty of fluid for resuscitation. We can also use blood, but that's not the main stay of treatment. For hypotension and those patients who have lactate more than 4, we're going to start an initial minimum of 20 milliliters per kilogram of the crystalloid, okay, which is your normal saline. And it's used to keep the mean arterial pressure. They would like it to be greater than 65 millimeters of mercury. The CVP should be between 8 to 12 millimeters of mercury. Okay, so fluid challenges with 500 to 1,000 mLs of crystalloid over 30 minutes may be repeated based on the blood pressure and the urine output response, as well as that individual's tolerance to the fluids. Okay, that's, of course, if somebody has heart failure and they're in septic shock, then you need to be especially careful and monitor that CVP and not put the patient into fluid volume overload. So it is kind of interesting that just because you have an acceptable blood pressure, it does not always mean that the patient is being adequately perfused. With septic shock, you would expect your patient to have 2 large bore peripheral lines, preferably if a central line. If possible, they want to be in the ICU with a central line. But if not, then we need 2 large bore peripheral lines. And by large bore, we're referring to anything like 14 gauge, 16 gauge, something like that. Not our typical 18 or 22. Okay, so we're talking about a 14 or 16 gauge, something around there, very large bore. This slide shows some of the latest evidence in treating sepsis, which we've already covered a lot of that already with our fluids, antibiotics, vasopressors. We cannot ignore the fact that this patient needs enteral feedings, nutrition, and hypercatabolism are occurring. So we need to make sure that we don't ignore that just because they're in the ICU. So we do have guidelines for nutritional support for these people. And we will consult with nutrition also to make sure that they get the adequate calorie requirements. Also, evidence shows here that maintaining a blood glucose under 150 milligrams per deciliter is associated with better patient outcomes and shorter ICU length of stay. Hyperglycemia is potentially harmful due to its procoagulant effect, impaired neutrophils function, impaired healing, and risk for infection. So we do have established insulin protocols that we will be using every hour. We'll do a finger stick to monitor their glucose and to control it. And certainly we talked about oxygenation and the oxygen demand, and that we can mechanically ventilate these patients. with up to 100% oxygen. So that's very important. And then we'll learn when we talk about mechanical ventilation later that this patient needs to be sedated for this ventilation to occur. Okay, so we want to address pain and sedation as well when they are intubated. As far as the nursing process for our patients with shock, nursing assessment becomes very critical. We need to do very good, for lack of a better word, assessments on our patients so that we can reduce complications that are associated with sepsis. We need to identify patients that are at risk of developing sepsis and performing focused assessments on these individuals. Okay, we don't go around the hospital looking to do focused assessments for every patient. We are nurses, we prioritize, we look at our patients and we identify which patients are at risk. Those would be the ones that we perform the focused assessment on. Okay. Here are some nursing diagnoses that are appropriate for our patients with sepsis and shock. First of all, of course, there's risk for shock, and that one is really huge because so frequently nurses don't discover or don't realize that their patient is in shock. So we have to make sure that we are doing those real good assessments and realizing that they are at a high risk for developing sepsis and shock. Those are the ones that you need to notify, especially if you suspect it. Then we're going to have the rapid response team may come down or they may transfer the patient to the ICU so that they can get the needed treatment there. A nursing diagnosis for shock. This is huge for us, okay? Because this is what we're studying, the concept of perfusion. Ineffective tissue perfusion peripheral. Yes, they become cool and clammy to touch, okay? Ineffective tissue perfusion, that's what we assess for. They could also have impaired gas exchange as a result of shock. They are certainly at risk for ineffective renal perfusion. So whenever there is a perfusion issue, the vital organs are at risk. And we need to make sure by monitoring renal function. We monitor urinary output on an hourly basis. We monitor lab results, the BUN and creatinine, to see if they're becoming elevated. You need to make that connection between shock and perfusion to the vital organs. Okay. They're also at risk of having imbalanced fluid volume. Because remember, we talked about those leaky capillaries throughout the entire body. Okay, so before treatment, they're going to have a fluid volume deficit. A relative hypovolemia because all of that tissue fluid is moving out into the tissues. Okay, all of the fluid part of the blood is moving into the tissues. Okay. Later, once we start fluid resuscitation, now they're at risk of an imbalance in fluid volume also, but on the other end of the spectrum. Now, with all those liters of normal saline being infused, they become at risk for fluid volume overload. That is why it is so valuable to have the CVP to monitor their fluid volume status. Some nice goals for this patient. the patient will maintain an oxygen saturation of greater than 92%. If you have ABG results, you can look at the partial pressure of arterial oxygen, dissolved oxygen in the bloodstream, and it should be within normal limits. That's another nice goal for these patients. The patient will maintain adequate renal perfusion. And adequate, we know a minimum is 30 mLs of urine per hour. Okay, that's a minimum. I wouldn't just be really comfortable just because I'm squeaking out 30 mLs of urine in an hour. And make sure you understand, if I would say a patient has a urine output of 20 to 30 mLs, is that adequate? I hope you agree that it is not. 20 to 30 is below 30, and so that is not adequate, and obviously the kidneys are not being perfused. Another goal would be the patient will respond to fluid resuscitation. And by that we mean that the mean arterial pressure returns to within the normal range. Okay. Yeah, that would be a great goal. That would mean that they are responding to the fluids that we give them, and then we don't have to go further and give them vasopressors, but instead the fluid resuscitation is successful in and of itself. So it's important to monitor the skin of the patient for perfusion. So that means we look at the color, okay? We look at, hopefully it's not cyanotic, okay? So cyanotic is a late stage sign of poor perfusion. We look at temperature. Is it cool or is it cold? We look at turgor. That would be for the hydration status. And certainly if they're dehydrated, then we're going to have the tenting. And that goes along with moisture as well. That would refer to clammy. That's when the skin is moist. It's clammy. So cool and clammy indicate that there is a perfusion problem. We can monitor the patient's cardiopulmonary function as well by looking at their blood pressures, their vital signs, their rate and depth of respirations. We're going to assess lung sounds, do pulse oximetry, and assess their peripheral pulses for their strength. And here in this picture, we see an arterial line, so we have a continuous blood pressure reading on the monitor. We can also monitor for things like JVD, because if the patient is getting into a fluid volume overload situation, then we may pick up on the JVD. We're going to monitor the central venous pressure, knowing the normal values and realizing that it is a range from low to high, and we would like it, depending where we are in the protocols, they'll have certain levels that we want to maintain, but we definitely don't want during a resuscitation to be on the dry side of things or the low numbers. Monitor the patient's body temperature. This is important as far as making the determination of SIRS and also checking on the progress of our patient in response to treatment. Monitor the patient's urinary output hourly, and assess the patient's mental status and level of consciousness, because remember that when the perfusion is affected throughout the entire body, throughout all the capillaries, all the microvasculature, this can have an effect in the cerebral hemispheres as well and can change mental status. And this goes back to our goals. This might be a little bit of repetition, maybe something new. We'll go over it. but the patient will maintain an oxygen saturation greater than 92%. We said, and that really is the lowest that I've ever seen a physician accept in my patient in the ICU. Okay, so we pretty much are given the orders to do whatever's necessary, whatever they need to maintain their oxygen saturation at 92. That's like the bottom of the barrel. After that, if you've done everything you can and you're not able to do that, then you need to notify the physician, because then that patient will likely be mechanically intubated and ventilated. The patient's blood pressure and perfusion should improve with fluids. As fluids leave the intravascular space, the patient's condition may decline. Yes, so I think you'll learn that in another article that I have for you. But even though we're giving lots of fluids, that fluid is not going to stay within the intravascular space. It will eventually seep out into the tissues. Okay, and so we have to continually monitor that fluid volume status because of those leaky endothelium that we have going on in the microvasculature. That fluid will seep out into the tissues. As perfusion declines, the patient's kidneys, heart, lungs, neurovascular status may change quickly. So we have to continually monitor these patients. And I probably say this a lot, but when you get into the ICUs and critical care, you're doing at a bare minimum of your hourly assessments on these patients. But truly you are continually watching, and you're continually monitoring that patient for any change, because you know as a nurse what the complications are. You'll learn about all the complications that can arise as a result of any condition. And so you're always on the lookout and monitoring for and trying to prevent complications.